So I'm Mike Mack. I'm a cardiac surgeon by background. I work at Baylor Scott and White, which is in Dallas. It's a large healthcare system in Texas. And I am the chair of the Research Institute and the associate medical director for cardiovascular disease for the healthcare system. So the PARTNER 3 trial, actually started about 10 years ago. And it was a trial of low-risk patients with aortic stenosis. The standard of care is surgery. TAVR had been shown to be non-inferior to surgery in high-risk and intermediate-risk patients, so this was the next logical population to study. So it enrolled 1,000 patients, mean age of 73 and mean STS risk score of 1.9. So it was truly a younger, lower risk population than had previously been studied. So the study designed was a 1-to-1 randomization of TAVI versus surgery. The primary endpoint was a composite of all-cause death, stroke, and rehospitalization at 1 year. And at 1 year, TAVI, to our surprise, proved to be superior to surgery. But that was mainly driven by rehospitalization and rehospitalization in the first 30 days afterwards. So we subsequently did annual follow-up and presented the 5-year results 2 years ago, which showed that there was some catch-up for surgery, so that by 5 years, the results were non-inferior to one another. The lines began to gradually close. So this trial is now the 7-year follow-up, and it included both clinical patient follow-up as well as echocardiographic follow-up. We're mandated to follow them up yearly by the FDA, but our next follow-up that we will report will be at 10 years because that's the next time that we're doing echocardiographic follow-up. And so the two, the big questions at this stage of things are, how long do patients survive, and do they survive with a durable valve? What we found in this trial is that at 7 years, with a primary composite endpoint of death, stroke, and rehospitalization, the results were virtually identical. There was a second primary endpoint, which was using a win ratio method of analysis, and it's a hierarchical composite, whereas the other one was a non-hierarchical composite. But the hierarchy was death, disabling stroke, and rehospitalization days. And surgery was better for the first two, death and disabling stroke. TAVR was better for non-disabling stroke and rehospitalization. So it ended up as basically a tie with a win ratio of 1.0 at 7 years. There's a limitation to any study. In any clinical study you do, the question is, how generalizable is it to the real world? And first of all, the results are applicable in only the population studied. So is this a class effect of TAVR, or is it device specific? I think all we can say at this point is it's device specific and limited to the SAPIEN 3 valve. Secondly, bicuspid valves, patients that weren't candidates for transfemoral access, and patients with complex coronary artery disease were excluded from the trial. The biggest point is, people have asked, well, now that this valve seems durable at 7 years, can and should this be used in younger patients? And, only a small minority of patients were under 65 in this trial. Nobody was under 60, and less than 8% were under 65. So you really don't have any data in a significant number of patients under 70 years old. Now, what we know from previous history with surgery is biologic valves deteriorate directly related to age. So the younger you are, a biological valve, tends to degenerate earlier in younger patients. So I think you can't justify going to younger patients with a biological valve. It doesn't matter how you implant the valve, whether it's TAVR or surgery. So I would just put that caution out there. But I would say the main thing is I don't think this is going to change clinical practice, but I think this is going to reassure clinicians that both are viable, durable options, and that if everything is optimal for TAVI, transfemoral access, no root aortic valve or root issues that are problematic, then TAVI is the right answer. But there should be equal confidence that if any of this is not optimal for TAVI, then surgery is just as good an option. Well, a couple things, the addition. Now, first of all, as I mentioned, these patients will be followed for 10 years. So we're just beginning to get the inflection point of where valves begin to deteriorate. So that is going to be, the 10 years is going to be very, very important in terms of valve durability. I don't think we're going to see a disproportionate mortality signal in one arm or the other this far out, because this far out, you have non-cardiovascular causes of mortality that tend to predominate. We're beginning to see that already. Third is we need the long-term results with other valves. Fourthly, is this FDA mandated method of following up patients. There was a disproportionate withdrawal of patients in the surgery arm of the trial. And we see this over and over again. And the reason for it is very simple. When patients get randomized to a control, they aren't as interested in following up afterwards. It's more difficult to get them back because they didn't get the new treatment, and we already know what the results are with the standard treatment. But it does create a selection bias in terms of analyzing outcomes. So the FDA mandated doing a vital status sweep, and what that means is the clinical sites reached out to patients, examined the electronic health records, went to public-facing sources of information such as what's called LexisNexis, newspapers for obituaries and things like that. And we were able to track down 95% of all patients for mortality. Prior to that, there was a disproportion for the primary endpoint of the trial. There was only about 90% of TAVR patients and 86% of surgery patients that we could follow up. But now we know mortality on 95%. And of the patients that were lost to follow-up, we confirmed that 3 TAVR patients and 13 surgery patients died. So this has proven to be a very important tool in terms of long-term research. Now, in other healthcare systems, it's not the problem like it is in the United States, where you have, national registries and available national health data. But it is a particular problem in the United States, and this is found to be a valuable tool to accurately compile the results of clinical trials. So the FDA mandates annual reports from trial sponsors of all results, and then these results are published publicly on the FDA website. There was a recent report from the intermediate risk trials of TAVI versus SAVR of a higher reintervention rate with TAVI than with SAVR. I think it was something like 15% to 2%. This is at 10 years. And we've gone back and looked at this data, and indeed, in one of the trials, which is partner 2A trial, there was a significantly higher intervention rate with TAVI than with surgery, but it was on the previous generation SAPIEN valve, the SAPIEN XT valve. We also looked at another 2,000 patients that were propensity matched with the SAPIEN, the current generation valve, the SAPIEN S3, and there was no difference in reintervention or mortality associated with that. So I think these were all appropriate concerns that have been raised, but when looking at current generation valves, that same signal doesn't seem to be there.